session is on change enabling in healthcare. So before I go on to the meat of my talk, I want to put 2 slides on how healthcare has enabled change in the entire human evolution. What am I talking about? Healthcare, human evolution. So I'll start off by asking a general question. We share 99% of our DNA with our closest cousins, the chimpanzees. But we have evolved, we say we are civilized, and human civilization has started. When do you think human civilization started? Any guesses? About 10,000 years back when we started doing the cave art that you see there. About 5,000 years back when we started developing the written script. Or about 3,000 years back when we built cities like Mohenjo-daro with roads, central town planning, and drains. When do you think human civilization started? Okay, so Margaret Mead, one of the world's famous archaeologists, was asked this question, and she pinpointed it. She said, we found this bone 15,000 years old on radiocarbon dating in an archaeological dig site, and she said, this is when human civilization started. And we're all like, you must be kidding. I thought you're going to show me these huge structures like the pyramids. You're showing me a small bone. So she said, this is not any bone, this is the femur, this is the hip bone. And you can see that it has healed in the middle. So a callus is formed. So this is a fractured hip bone that has healed. In those times, or even now, a fractured hip bone takes 6 weeks to heal. During the 6 weeks, the animal which has got a fractured thigh bone cannot walk, cannot fetch water, cannot hunt, cannot run from danger, and no animal with a fractured hip bone will survive. And the fact that this human has survived 15,000 years back means for 6 weeks while this bone was healing, somebody looked after him, protected him, shifted him, fed him, and took care of him. And this is the index of human civilization. And this sort of healthcare is where human civilization started. So compassionate healthcare, which we are all involved in, is the hallmark of the beginning and continuation of civilization. So quickly moving on to the meat of the talk. So we did a small study. There was a lot of talk about wearables coming in. We all have smartwatches which measure our heart rate and blood pressure. And my pain point was, as a critical care doctor, we had patients in our ICU who we could monitor continuously for 24 hours every day. And then after a short stay in ICU, we'd move them to the ward. And then they would be monitored once in a shift or twice in a shift, once every 4 hours, once every 8 hours. And some of these patients who we spent a lot of time, patients spent a lot of money, a lot of effort in getting them better, would have a cardiac arrest and come back. So this is one of the standards that we monitor, and I'm sure a lot of other hospitals monitor as well, the number of cardiac arrests that we have in the hospital, the code blue calls. So we decided that we would try and trial a system that had come into the market at that time called Life Science, which is an FDA and CE approved wearable monitoring device. I thought, let us try this so that we can have seamless, continuous wearable monitoring on the wards as well. And because it's wearable, patients can walk about, take part in physiotherapy, go to the bathroom and come back and still remain continuously monitoring. So we did this trial period for 3 months. It was a before and after study. We decided to compare our data that we had now for the number of code blues we had now versus once the start of the study. So we had about 3 to 4 cardiac arrests every month in our hospital. And we started this study and we decided to use this. And one of the changes we made was we ensured that the whole hospital was Wi-Fi enabled. We ensured that we had a hospital dashboard, and we also ensured that we had 24/7 presence of ANMs. And the presence of ANMs was the one that made this study possible, because when we started using wearable monitoring, one of the things that happens is there is an increase in alerts. We monitor continuously the heart rate, saturation, respiratory rate, temperature, and every time there are slight variations from this, an alert goes off, and nurses who are already overburdened get an extra call. So we decided to filter this. We created a hospital dashboard. We put an ANM there whose only job 24/7 was to look at these alerts, and whenever there's a flashing red sign, to go to the patient side and check on the patient and make sure that this is not a false alert, and if it was a real alert, to escalate it to our normal medical emergency response system. So on the left side top, we have a dashboard which is looking at about 20 patients who are wearing this wearable monitor. We can go in, as you can see, and look at each patient's ECG. We can look at trends, and the patient is comfortable because it's stuck onto the chest. They can take a shower, they can walk around, and there are no wires that are tying them down to a monitoring system. So this was the outcome of the study. So we studied about 225 patients. We looked at the patients that were transferring back. And as it happens, this is a very small study. And the number of cardiac arrests of 2 or 3 per month is not something where we can get a clear outcome with such small numbers. But we found that during the 3 months that we were doing the study, there were 0 cardiac arrests. And we've gone on to use this system in more of our hospitals. We're a chain of about 8 hospitals, so now this system is now being adopted in other hospitals as well. So what happens is we are able to pick up patients before they reach the point where they have a cardiac arrest, as they are deteriorating, and the medical emergency team goes, recognizes it, and brings them back. And a various set of parameters are being monitored, and more are being added. At that point, we did not have blood pressure, but now blood pressure is added as well. What do the studies say? So a lot of studies, all of them in Western patients, about 200 to 300 patients each, except a couple. All of them are showing that by using continuous wearable monitoring, we are able to make a difference, and we're able to detect patients earlier before they go into cardiac arrest. Although statistical significance is not yet achieved, there is a clear trend towards improvement. So where do I see this going? I see this reaching a stage where we will have more Indian studies. There's quite clearly a signal for benefit, and this benefit will be more when we're dealing with risky patient populations rather than fit and healthy people. And this will be integrated, not just vital signs, but you can have the vital signs integrating with blood results, with radiology, and with AI coming in. AI will alert and say, look, this patient's got a patch on the X-ray, the white cell count is going up, oxygen is going down, this patient has got a pneumonia, have you taken cultures, have you started antibiotics? And although AI will not replace healthcare, they will definitely start providing an invaluable assistance to us. Thank you.
Thank you, Sridhar. I think you've heard 3 different views of change. One, they all, interestingly enough, started with history and sometimes ended up in the future. I thought you were going to scare us saying that AI will substitute. So let me say my vision a little bit for the future. I hope that today we have a number of clinicians sitting on the stage sharing innovation. I hope that next year in CAHO's Changemakers, perhaps we'll have quality heads, perhaps we'll have nurses, perhaps we'll have admin, because they represent large chunks of our clinical population. And I think that is what we would like to see more of. So it's not just that you have to be a clinician to be a change maker, but I think these clinicians have obviously done remarkably well.